Please take your seats. We're calling this meeting to order. All right, we'll begin with roll call. I'm Charles Macias. I chair the PEDS subcommittee. And if you are not staying for the PEDS committee, can I please ask that you carry your conversations outside of the room? Thank you. Thank you. All right, so we start with roll call. Charles Jaquith. Here. Diana Krause is not with us today. She did send her comments. Julie Lewis. Present. Aaron Lincoln. Here. Sally Snow, I believe, had a conflict. Sam Vance. Here. Vern Walker. Here. Ramsey Tate could not be here. Stacy Steens. And Ron Milken. Here. All right, thank you. So we'll begin with our committee liaison reports. We start with Air Medical. Julie?
I was unable to attend the February meetings, but in talking with some folks from the Air Medical Committee, sounds like the only thing that has a pediatric concern is they're continuing to work on the pediatric recognition program for providers. I'm not sure when that will be complete, but. Can't hear you. Oh, I'm sorry. Is that better? Yes. They continue to work on the pediatric recognition program for all providers, and that's the only thing that pertains to pediatrics.
Okay. And do we have some kind of sense of the timeline?
I do not.
Maybe we could provide that so we have an understanding of when they'll have opportunity for employment to review. Okay, next EMS, Vern.
I also missed the February meetings. However, in the November meetings, the only thing really that pertained to pediatrics were the items brought up by EMSC. I will attend tomorrow's meeting and see if there's anything else. If anybody else was there at that EMS meeting, it would be, you're welcome to let us know if I've missed something from that. But the website's been down, so I've been able to go and find the minutes to be able to read those.
Okay, thanks. Next is education. Charles.
On February GTAC meeting, education did not have anything at that time concerning pediatrics, and we have not had another meeting about the community paramedicine since then.
We have Diana Krause not present for injury prevention. Medical Director Sam.
Unfortunately, in February, I had to leave early, so I do not have a report from the medical directors.
Colin, do we know when the website will be back up?
We do not.
There seems to be
Unfortunately.
multiple gaps in information.
Yes.
All right. Stroke. Aaron.
Following the trend that we seem to have going here, I was also not able to make the meeting in February and also not able to consult the meeting minutes on the website. So I'll see if I can't get in touch with somebody on the committee to get an update.
Okay. Sally had trauma systems. I believe her update was was not a new concern that she forwarded. Regional the RAC chairs meeting. Ron, do we know when the next meeting is?
Do not, sir.
The next direct chairs meeting is this evening after the Air Medical Committee meeting adjourned, so about 5:30 in this room.
Will you be present at that?
I will do that, yes, sir.
And disaster planning, we just heard the last meeting. And I think we can wrap that PD discussion, the recognition program, into Dr. Remick's presentation with the discussion. Perfect. So let's move on to the core content. We start with an update on the child fatality review state activities. Perfect. So if you wouldn't mind introducing yourself.
Sure. My name is Amy Bailey, and I'm the Texas Child Fatality Review Coordinator at the Department of State Health Services. I have two updates. The 2015 Biennial State Child Fatality Review Team report has been published and submitted. And so that report is available online, contingent when the website gets back up and running. So that report is available to everybody. It contains data for 2012 and 2013, as well as recommendations from the State Child Fatality Review Team. The graphics that are in the report are available for anybody to use, and so we really welcome people to use those graphics and presentations and promote that and support that.
Do those require permission to use? Do we just need to notify, or are they?
So what will happen is we are going to upload a PowerPoint to the website, and they'll have already, it'll be a picture that you just cut and paste off the PowerPoint, and it'll have the reference on there already.
Perfect. Thank you.
And then we are currently working with UT Health Science Center in San Antonio. They are conducting a survey with all of the child fatality review coordinators in Texas to see how they code deaths in their jurisdiction. And we're really hoping that this improves data quality among the data around Texas for teens. So that's exciting, and we hope that coordinators really fill out that survey and work to, complete it so that we have good data from all the jurisdictions in Texas.
Do you have a sense of when recommendations for standardization coding would emerge from that?
So we are hoping to have all of these filled out by midsummer, and then we'll have recommendations in FY17. They'll be going out, and I can't say exactly when, but so it just depends on how long it takes everybody. We like 100% completion, so we're going to work towards that.
It might be nice to try to tie that in with what will become our annual EPI report
Okay.
in the February meeting.
Wonderful.
So if we could target that, that would be
Absolutely.
perfect. Anything
Okay.
else?
Thank you. Nope.
Thank you so much.
Thank you.
So we had potentially, we were working on discussion with the Center for Prevention of Child Maltreatment, and we had invited Dr. Daly. I think there was a conflict, so we will move that into our next meeting. And it really was to talk about infant mortality and some of the strategies in data collection, so we'll move that discussion. So we have next a guest presentation or discussion really, and it's an update on the National Pediatric Readiness Project by Dr. Kate Remick.
Hi, I'm Kate Remick. I'm a Peds Emergency Medicine physician, EMS physician. I have been working on the National Pediatric Readiness Project for the last 6 years now, I guess, since its inception. The idea, again, is to improve the ability of our emergency departments to be able to stabilize and manage medical emergencies. I think you all were aware of the national assessment that went out in 2013, which showed continued gaps in the ability of our nation to really meet the needs of children on a day-to-day basis. And so there's been a number of efforts that have moved forward since that time. Each of the major national organizations that were involved in writing the guidelines, the Emergency Nurses Association, the American College of Emergency Physicians, and the American Academy of Pediatrics have all taken on individual projects to try to improve readiness on a national scale. The Emergency Nurses Association is facilitating the development of state champion teams, which include representatives from each of those organizations, as well as the State EMS for Children Partnership Program Managers. And the idea of those is to really be able to map hospitals within their state and help facilitate at the local level the identification of pediatric emergency coordinators and the implementation of quality improvement processes around children to improve overall readiness. They're going to be serving as a resource on the state level to be able to provide education to those facilities. The American College of Emergency Physicians is working hard to develop some metrics for quality improvement and try to garner support from community physicians that work in community EDs. And then the American Academy of Pediatrics, we're working to develop a quality improvement collaborative to really help teach providers, both nurses and physicians, as well as EMS providers, how to develop quality improvement processes and activities at the local level. So that's going to be rolling out hopefully within the next year, developing various platforms, including webinar series and conferences, etc. More specifically, on a national level, the EMS for Children Innovation Improvement Funded. This is going to be taking over the National Resource Center. It was granted to Baylor College of Medicine. Dr. Macias is the primary principal investigator for this, who knows it very well. But the goal is to begin to use quality improvement methodologies to support all EMS for Children grantees on a national level towards improving overall emergency care, but include readiness, both at the pre-hospital level as well as the hospital level. And then finally, the one thing I wanted to mention is the importance of pediatric facility recognition, and that goes to the next item on your agenda. We know that more than 80% of children are seen in non-children's hospitals, and we know from that 2013 assessment that there are still gaps, the median score being 69 on a 100-point scale of the 83% of hospitals in the United States and U.S. territories that responded and participated in this survey. We know that many of those gaps include even beginning to look at the pediatric patients that come into the emergency departments, and when we're talking about 80% of children, whoops, just lost my mic. Do you want me to just yell?
Why don't you come here?
Okay.
Yeah.
Sorry about that. When we talk about 80% of children being seen in non-children's emergency departments, it becomes critical that we at least look at the care that's being provided to those children. We know that less than 50% of hospitals have quality improvement processes in place to care for children. We know that less than 50% of hospitals have disaster plans in place that include children, and there are numerous other gaps. We also know from the assessment that having just one champion at the local level, a PEDS emergency care coordinator, greatly improves readiness, as do quality improvement processes. Those are both associated with almost a 30% gain or 30-point gain in overall readiness. There are 14 states so far and/or regions that have developed pediatric facility recognition programs. The idea is similar to trauma centers, where you recognize a facility as being ready to meet the needs of children, but rather than on the level of injury, we're talking about medical illnesses for children. And because so many children are seen in non-children's hospitals, this becomes critically important. Because many regions have developed these programs, we've now been able to look at how that impacts overall readiness. In the state of Tennessee, they actually have a mandatory program that's been in place. They have the highest level of readiness scores of any other state in the nation, with readiness scores approaching 90% across the state. The state of Illinois also developed a very robust pediatric facility recognition program that's voluntary, where they have a large number of hospitals participating. Over 60% of hospitals in the state participate in that program. And then in the state of California, they also have a robust program. And in that state, we were able to see huge improvements in pediatric readiness. What we'd like to do is see how we can make our communities more robust to meet the needs of children in the state of Texas. And the ask of this committee is, can we at least support in concept the idea of pediatric facility recognition, and then begin to, if we can get a general consensus that we support this and we want to build up our communities and bolster our communities to meet the needs of children, then we can begin to look at how. But really the ask right now is just, is this a good idea, and how can we meet the needs of children?
Dr. Raymond, can you speak to alignment with professional societies and other organizations?
Yes, absolutely. So I'll speak first about the guidelines for readiness. We're really talking about basic levels of readiness. So do you have a quality improvement process in place? Do you have patient safety measures in place for children? Do you have supplies and equipment for children? Do you have policies and procedures for children? The majority of hospitals are fine in terms of supplies and equipment. It's the other areas that are lacking. Those guidelines have been endorsed by numerous professional organizations, including the Joint Commission, the American Heart Association, the American Medical Association, the Children's Hospital Association of America, and numerous others. They were written by the Emergency Nurses Association, the American College of Emergency Physicians, the American Academy of Pediatrics, and is also endorsed by the Federal EMS for Children program. In terms of pediatric facility recognition in Texas, we've begun discussions with numerous stakeholders. We've been talking to TTAF, we've been talking to the Texas Hospital Association, we've spoken with the Texas Office for or Torch, we'll just say Torch. We've also received formal endorsement from the Children's Hospital Association of Texas. We've received formal endorsement from Sam, fill me in here on who else has. Thank you.
We've also received formal endorsement from the Texas Emergency Nurses Association, the Texas Pediatric Society, which is the Texas chapter of the AAP, and the Texas Parent-to-Parent Organization, who is the EMS for Children Family Advocacy Network.
Thank you. And we would like to continue those discussions. We've also begun discussions with the RAC chairs as well. And again, this is not how do we implement this, but should we at least support in concept the idea of pediatric recognition.
So I think it's an important organizational history component here that's worth mentioning. That is that the effort itself was begun many years ago. And part of the challenge with only quarterly meetings of GTAC is that we lose memory for those activities that occur in those endorsements. And so it has become rather cyclical that we engage professional societies, they forget their endorsements, and then we're back again. So I think what I'm hearing is this strategy of sort of a two-part endorsement where in concept we endorse, we move forward, and then subsequently an implementation plan would be proposed.
That is correct. With the input of all stakeholders.
Perfect. So do any of the members have any questions? And is anyone offering to put forth a recommendation for endorsement so that we can second and vote?
I'll make a recommendation for endorsement.
Does anyone second? Perfect, Vern. So all in favor? All right, thank you.
Thank you very much.
Just one question. Do we think it reasonable to anticipate an implementation plan in November-ish?
We'd like to bring together a group of stakeholders towards the end of September to at least begin discussions as to how this might be implemented on a state level. In terms of when that plan will be developed, it's difficult to say the exact timeline, and I think it depends on the goals of that group.
Perfect. Thank you. All right. We next have EMS for Children State Partnership Update. Sam.
So just to tack on a little bit to what Dr. Remick had said there, the stakeholder meeting that we are planning, we have the date set for September the 26th. It will be at Dell Children's Hospital here in Austin. We will be sending out invitations soon, more than likely after this week. And if anybody is interested in participating in that stakeholder meeting, that I may not have your contact information, I would ask that you please get in touch with me. And then as far as facility recognition is concerned, the National Resource Center has developed an expert panel to form a quality improvement collaborative in Washington, D.C., and the Texas EMS for Children State Partnership has applied to that and has been accepted as one of 11 participants to participate in this quality improvement collaborative to look at facility recognition. and we have engaged two of our stakeholders, the Texas ENA and CHAT, to participate with us, and we will be traveling to Bethesda, Maryland later in this month for our first meeting. Also along those same lines, talking about the National Pediatric Readiness Project, just to remind everybody, the Pediatric Readiness Portal has been reopened. If your hospital would like to redo the assessment to see how you compare now to your 2013 score, or if your hospital did not ever participate to begin with, you can take the assessment and to get your initial scores. Before I get to that, the Pediatric EMS Recognition Program, we went to Amarillo back in March to kick off the pilot of that program back on March the 18th. Since then, we have had one system that has completed the assessment process and will be recognized as an EMS agency capable to care for kids. And not that you'll probably be able to see it out there, but I do have, these are the decals that we have that will go on the ambulances, that folks can put on their ambulances once they receive that recognition. And since then, we have also had a second hospital, the second EMS agency in the Amarillo area who has applied for the recognition process. So we're excited about that. Then, as y'all may know, next week is EMS week, the Wednesday of Yes, sir.
So I think one of the questions that has come up repeatedly is perhaps a little lack of clarity between the two recognition programs. Can you just run through the distinction between the two?
Sure. So the EMS recognition, as the hospital recognition program, both are voluntary. The EMS recognition program obviously is specific to EMS. The hospital recognition program is specific to hospital emergency departments. The EMS recognition program has already been vetted and approved through all the subcommittees of GTAC as well as the GTAC Council. The facility recognition program, or the hospital recognition program, we are in the process of this week to just gain endorsement of the concept. We have not even made any planning stages as to what that program will look like. The EMS program is completed. It is a tiered system to where folks will be recognized for going above and beyond what is required by the state for things such as protocols and equipment, continuing education, and community outreach. And as I said, with the hospital recognition program, we don't know what that will look like yet, and hope to begin developing that process at our meeting in September. But as far as the hospital programs are concerned, as Dr. Remick pointed out, it is a quality improvement process to make sure that our hospitals are taking care of kids consistently across the board with things such as a nurse or physician pediatric coordinator, inter-facility transfer guidelines, things such as that. And so as far as national recognition is concerned, as far as the, the medical recognition is concerned, as Dr. Remick pointed out, there are 14 states that currently have these programs. As far as the EMS recognition program is concerned, to my knowledge, we are only the 4th state that has an EMS recognition program, and actually our EMS recognition program is being used as a model for several other states that are developing similar programs. So I hope that answers your question. Sure. So, yes, so Dr. Macias asked if I could speak to the national performance measures that speak to these. As most of you are probably aware, the EMS for Children program is federally funded from HRSA, and HRSA has performance measures that we try to meet. The performance measure number 74 is what speaks to the facility recognition program, as far as all hospitals in the state should have a system in place to address pediatric medical emergencies. As far as the EMS recognition program, you have performance measures 71, 72, 73, and 78, I believe it is, that speaks to EMS equipment, EMS protocols, online, offline medical direction, as well as performance measure 78 speaks to EMS continuing education. Okay. Then, so moving on to EMS week, next week. Every Wednesday of EMS week is the EMS for Children Day, and every year we give out our Crew of the Year award. This year, the recipient of the award is Children's Health or Children's Medical Center Dallas, their transport team. They are the recipients. We will be presenting that award next Tuesday. It appears to be we will be doing it at their hangar out at Love Field at 10 o'clock in the morning. So all of those of you in the Dallas area that can make it, we'd love to have you. Then, let's see. The last thing that I would like to talk about is something that we've kind of brought up over the last year or two, that it's the integration of the EMSC Advisory Committee with the Pediatric Committee here. Myself, Dr. Macias, our EMSC Program Director, Dr. Shaw, have spoken on several occasions with members from DSHS, including Jane Guerrero, regarding the process. Dr. Macias has also, yes, and with Dr. Macias has recently spoken with Dr. Greenberg, who is the interim and will more than likely be named the chair of GTAC. And they are all in agreement and on board with this concept of integrating the two, which to me just makes sense because there's a lot of redundancy between the two committees. There's a lot of overlap, a lot of duplication of efforts, and a lot of additional work that exists between the two committees. So integrating the two would definitely make things more efficient. So many of the folks that are on this committee are already core members of our EMSC Advisory Committee. And as I mentioned a while ago, HRSA EMSC has performance measures that we have to meet. Performance measure 79 specifically states that we have to have an EMSC Advisory Committee with 8 core members, and that HRSA strongly recommends that this advisory committee be state mandated and be part of the state EMS committee system, such as being the Pediatric Committee. And this is how many other states do it. And so per those guidelines, we would have to have the 8 core members on the Pediatric Committee. Those 8 core members are a nurse with emergency pediatric experience, a physician with pediatric training, an emergency physician, an EMT or paramedic who is currently working on a ground ambulance, EMS state agency representative, the EMSC principal investigator, the EMSC grant manager, and a family representative. I believe that this committee currently has all but 3 of those positions currently representative. So what we have discussed is that when a current member's term expires, that they would be replaced with one of those core members. Or we have also discussed the possibility of just adding those additional members to this committee. Nothing is set in stone, and that's why I'm kind of bringing it up here to y'all today in this public forum, that we can discuss this to get your thoughts and opinions on this. And
so in terms of day-to-day functioning, we don't anticipate any kind of change. I think what it does provide is greater transparency to this group as well as to the public for the ongoing workings of the EAC. The content or the composition of the groups would essentially merge. Just by way of transparency, there really aren't set criteria for members of the committee other than we aim for geographic diversity. So additional asks would provide some sort of guidance for what a balanced and standardized look to the committee would feel like. And Colin, correct me if I'm wrong, but we don't have a cap to the number of members, although we want to be relatively reasonable.
That's correct.
Okay. So there's a lot of leeway between 8 and the 13 that we have to keep membership responsive to the needs of the state as well as to the needs of the nation and integrate those efforts. So although we have reserved public comment at the end, I think because this is a change in structure, it would be very important for us to get your response, your gut reaction to what merging those two committees would look like. Specifically, if you have any concerns. So I'm going to take that as meaning you have perfect agreement. That's great. Thank you. Dr. Remick.
May I ask a question, which is, would there be an opportunity for the EMS for Children program to be able to retain some governance over who is appointed for at least part of the committee, and then GTAC the other? I don't know how that would work, so that we make sure that the two goals of these committees are truly fully integrated.
So my gut reaction is to say it probably would not be governance on the EMSC side, because the true governance group is the committee in the state. But I think that the content and the recommendations that are put forth are taken very seriously. I think I've been in this role for 5 years and been with the committee for 7 beyond that, and I've never felt that the larger organization has ever not respected the recommendations of either the groups, the committees, or the members individually. So I think it's a great working relationship. I don't anticipate that that would in any way be deconstructed.
Okay.
Hello, Alicia McDonald. I'm a flight paramedic here in Texas. Some of the first kind of questions that came to my mind, that's a significant number of your committee that would be it would be a majority vote, basically, of EMSC board members. That organization is a volunteer organization. It's driven from the national level. Obviously you pick things too that work for you locally that may not be a national initiative, but that might be construed as a national initiative driving your committee. So, and that's kind of where my concern is. I'd be curious to see what DSHS Legal had to say about, the diversity of the group, how you do that, and then how the agenda is pushed. And if you could have a majority of the people who are also acting in the other capacity at these tables. I understand we do a ton of things, so a lot of people are on like multiple committees and things like that. And they do overlap. But. So
just one point of clarification. So the EMSC membership is the EMSC state partnership membership. So it still is state priority. We are in a unique position than the other 50 states in that we now will become, not this group, but some crossover will become the national coordinating center for quality improvement, which is the national coordinating center for EMSC. But that membership really has no specific dictum or prescriptive agenda for one particular state. Whatever's offered to the states as guidance remains as guidance. But ultimately, the membership of the state, EAC, is where we see the crossover. So does that feel better if your knowledge is that the EAC is state-specific?
I think generally, overall it sounds great. I think it has a feeling, though, that it's still nationally driven, pushed down, and that this committee would kind of change into something else. And again, it'd be interesting to see, especially if you dictated positions that had to be on this committee, and then also who had input in that. So.
I think that there are process, and this brings up a very relevant point, because I think one of the things that, should we move in that direction, that we could certainly do for transparency, is to start agenda items with what is national recommendation and what is purely state. And that way, it will become very clear what is. So as we look at our agenda today, for example, all of the committee interactions are all state. Number 1, child fatality reviews, is all state-driven. Number 2 and 3 are national. Number 4 are state-supported. 5, 6, and 7 are state. So I think the vast majority are state. But I think I like it, if that feels right, I think that every agenda item can be labeled that way for transparency. And then to your question of the legal nature, so we did run that past Jane. Colin, is there an additional step that we need to undertake?
I'm not sure. I need to actually visit with Jane on this issue.
Don't look for the answer on the website, though, because...
No, that's right. Don't.
All right. No. Oh, Dr. Shaw.
Manish Shah, I'm the EMS for Children State Partnership Program Director. I just wanted to clarify the role of EMSC in response to the last public comment. The purpose of the EMS for Children program is to be integrated into the existing EMS infrastructure. So if the EMS for Children state partnership is to be truly integrated into the infrastructure of Texas, then the opportunity of integrating what the EMSC Advisory Committee for Texas does into the Pediatrics Committee of GTAC is in line with that mission. So I think that's an important point to make, that that although there are national performance measures that are established by the National EMS for Children program, that the state partnership is meant to specifically focus on what's important for their own state. And so the EMS for Children State Partnership in Texas is meant to focus on Texas and to enhance pre-hospital and hospital-based emergency care for children in the state of Texas. And so the purpose of the advisory committee is to ensure that there's adequate stakeholder input within Texas to make sure that what the state partnership focuses on is important to that state. So I think that although there are some national things that are defined as priorities, the EMSC advisory committee within a state really sets the agenda for what's important and what should be priority to work on in that state.
Thank you for the clarification. But I also think that the comment brings up an important point about transparency and access to that content. And so, and I really don't know the answer to this, but what are the measures that the state partnership takes to assure that the constituency of the state has opportunity to offer direction? And this is beyond the EAC. So we know that the EMSC Advisory Committee offers recommendations, provides direction, but how does the public feed into that?
And I think that's a great question. And the way that we've approached that historically, at least for the past 7 years, is that we have tried to not set a limit on who is on the advisory committee, that if there are interested stakeholders that we feel somehow participate in the process of providing emergency care, whether it's pre-hospital or hospital-based emergency care for children, that we want to hear what they have to say. And so we have been very proactive for the past 7 years in inviting a variety of stakeholder groups to participate in the advisory committee to date. So I think that is how we have done it. I think that since there isn't a cap on how many members could be on the GTAC Pediatrics Committee, I think it still is a possibility that would still foster open stakeholder input, but I think that for the efficient working of the GTAC Pediatrics Committee, that needs to also be evaluated because the process would be a little bit different.
So just a parallel concept in the Institute for Healthcare Improvement, one of the interesting ways that the IHI looks at a bottom-up, very granular stakeholder engagement is they create an idea board, which is their front door to say, if you are a member, a citizen of the U.S., even if you're not, and you have an idea about what can improve quality of health care, you bring it to their idea board, and every single idea is processed and feedback is given back to the constituency. But the point is, it doesn't depend on a handful of people to translate that there is a process. I'm wondering if that last comment doesn't reveal that there might be an opportunity to open a more direct discourse between the public and what the EAC and this committee is doing.
Yes, absolutely. And I think that the way each state has their advisory committee structured varies, and many states do what you've suggested.
Yeah. All right. So we'll look forward to an update on that.
And that's all that I have.
Okay, great. Thank you, Sam. We are going to defer the update on Texas consideration for pediatric consultation and transfer guideline action plan. The action plan was submitted and reviewed by the large GTAC committee, and Colin, I'm going to need some guidance on whether that required an official approval. I wasn't really clear on what that next step meant for that document.
Yeah, I believe it needs an official endorsement by the council.
Okay, so if that had been presented at the last meeting, does that mean it will be reviewed for endorsement at this meeting?
If it's already been endorsed, no.
Okay.
So,
all right, this might require an online discussion to
okay.
understand how that's executed. All right, thank you. Next item is the Texas EMS and Trauma Registry's pediatric report status update. Wonderful.
Good morning, committee members. I am Dan Dow, joined today by Stacy Jorgensen from Injury Epidemiology and Surveillance Branch of Department of Health Services. And we provided the 2014 pediatric report in April. We would like this report to be delivered at the first GTAC or the February GTAC of each year. We also asked that Diana Kraus be assigned as our subject matter expert during the creation of the report. And now I'll hand it off to Stacy Jorgensen to do a presentation on our report.
Colin, that does not require any kind of vote, correct? That we make annual or February report and that we identify our own internal liaison?
I don't think so.
I'm going to take that as a no.
Yeah.
Thank you. Okay. Well, she's already our designated person. Yes. See what happens when you don't show up for your meeting?
All right, Dr. Macias and the rest of the committee. Today I'm going to summarize the 2014 EMS and trauma hospitalization data for the Texas pediatric population. Pediatric here referring to individuals less than 18 years of age. Submersion data is going to be provided in a separate report that is nearing completion. And if you have seen the 2013 pediatric report, the content of this presentation is going to look very familiar. As you are no doubt aware, the Injury Epidemiology and Surveillance Branch runs the EMS and trauma registries, which collect legislatively mandated data reported by EMS providers as well as trauma hospitalization data meeting specific criteria summarized here. I'm going to start with our EMS data. We had almost 192,000 pediatric EMS runs in 2014. This was down a fraction of a percent compared to 2013. And as in 2013, pediatric EMS runs were about 8% of all EMS runs in the state.
I'm sorry, you said 8%?
8%, yes, or 7.9%. These data are county-level crude rates for EMS runs in the pediatric population. They have not been age-adjusted. Additionally, the crude rate was only calculated for a county if they had at least 20 pediatric runs over the year. The counties colored white did not have a minimum of 20 pediatric runs in 2014. Darker colors indicate a higher rate of pediatric EMS runs. You can see there's considerable variation among counties, although there's no clear geographic pattern to these rate differences. Our lowest rate of pediatric EMS runs was in Parker County, which is west of Fort Worth, and just a couple counties to the west of that was Callahan County, which had the highest rate of pediatric EMS runs. Most of the large cities or the counties with large cities had intermediate rates of pediatric runs. We had nearly 36,000 trauma-related EMS runs in the pediatric population, and this was about 1/5 of all pediatric EMS runs in the state. These data are for trauma EMS runs only.
I'm sorry, can I ask a question real quick?
Sure.
So the counties that weren't included, that had less than 20 EMS runs, these are just the agencies that are actually submitting data, is that correct?
Correct. I can only report data that have actually been submitted to the registry.
How many agencies submitted that data to the registry? Do you know?
I don't know. It's certainly hundreds of agencies.
Right. We have, Colin, nowadays about 900, give or take, 911 agencies in the state. Is that correct? So I would just be curious to know if we had 400 agencies submitting data, 500, how many agencies actually submitted data to this?
We'll look into finding that out for you and possibly include it in our report next year. So as I mentioned, these data are for trauma EMS runs only. In 2014, males were 51% of the pediatric population. So you can see they are overrepresented among trauma EMS runs in the pediatric population. And among the different age groups, teens from 14 to 17 had the largest number of trauma EMS runs. When we look at children less than 15 years of age, those younger than 1 have the largest number of EMS runs, trauma EMS runs. For temporal variation, we have a pretty strong diurnal pattern that is observed. About a quarter of all trauma EMS runs in the pediatric population occur between 4 and 7 p.m. And we did also have a slight seasonal pattern that showed up in our pediatric trauma EMS runs. You can see that the months of November through January, or through February, have fewer pediatric trauma EMS runs. We had almost 30,000 records with external cause of injury codes, making it possible to classify injuries by cause and intent. Here I am just showing the top 5 causes of injury for trauma EMS runs among Texas's pediatric population, and I don't think anyone would be surprised that motor vehicle traffic and falls are at the top of the list. 83% of all traumatic EMS runs related to unintentional injuries, and only 7% were assault related. Onto the trauma hospitalization data. We had nearly 22,000 records submitted to the registries for 2014, and nearly 99% of these trauma hospitalization records were for non-fatal injuries in the pediatric population. We see an even more dramatic gender skew in the trauma hospitalization data, in that nearly 64% of children who were hospitalized for traumatic injuries were male, and they were greater in number for males in every age group. And for both sexes, the largest number of trauma hospitalizations were for children less than 1 year of age. The fewest number of trauma hospitalizations was at 10 years for males and 12 years for females. And I just want to point out that adolescents had the largest, what we might call gender gap between male and female trauma hospitalizations. Among our pediatric trauma hospitalization records, 22% had a diagnosis of traumatic brain injury, either with or without a spinal cord injury. And we saw dramatic differences when we looked at our fatal versus non-fatal records. As I said, almost 99% of our records were for non-fatal injuries. When we looked at our fatal trauma hospitalization records, 57% of those records involved a diagnosis of traumatic brain injury. And as with the EMS trauma runs, we have motor vehicle traffic and falls at the top of our list for the 5 most common presented here, external cause of injuries, although they've flipped positions, with falls being the #1 cause of injury among pediatric trauma hospitalizations and motor vehicle traffic #2. All right, and that is the end of the summary. We do have a temporary website up. There isn't a lot of information up there right now. As you are aware, the DSHS website is undergoing maintenance. So this provides a brief amount of information. I've provided the contact information for our epidemiologist.
So in Diana's absence, she did request 2 things. The first is it possible for some stratification of children greater than 15 versus younger than, given that a number of facilities don't take children over that age, so it helps us to understand how trauma is differentially managed, since there would be factors that would contribute given the difference in setting. Similarly, the same kind of stratification for the number of pediatric admissions to adult facilities, trying to understand the difference between outcomes in the adult facilities, which partly may stem from who's actually being transferred to adult and pediatric facilities. That information is partly to understand how it fits with the facility recognition, to help us understand where we need to be targeting efforts for pediatric readiness. So the stratification is possible.
You want a stratification between adult versus pediatric
facilities and then
and
between,
also
with the age stratification as well.
Yeah,
So those 2 levels.
I think that's something we can certainly do with the data.
Dr. Remick, you had a comment, question?
Yeah, I mean, it's a fantastic report. Looking at one of the slides, it was obvious to me, though, that there were about 54% of children that were transported by EMS that were medical emergencies as opposed to traumatic, as well as a large percentage that were other, classified as other. And it would be fantastic if we could see a report similar to this for pediatric medical emergencies or EMS transports. And then I think that also brings to the question of how do we begin to get at registries related to pediatric medical hospitalizations as opposed to trauma? Because that would also be fantastic to know. Yeah.
We did include in the official pediatric report, we do have data on the medical EMS runs. I just didn't present them today because we're mostly focused on trauma.
Okay.
And in the interest of time. But it is available in our report.
Thank you.
You're welcome.
Hi, Lisa Nichols, and I'm with a trauma program manager at Dell. One of the questions that I have also with the Texas TQIP project that we're currently working on, traumatic brain injury is actually one of the breakouts that the data that we're actually developing reports and stuff for, looking at results. Currently, it's mainly focused only on adults, but I'd be curious to know that if we have the TQIP information and stuff for pediatrics, because currently it's not being incorporated in Texas TQIP, if we could somehow incorporate some of that data as well within some of the report that you're getting. So it would give us a little bit better breakdown from a pediatric standpoint that we're currently not really looking at, but kind of give us an idea as far as what types of things we're putting in the registry, if we're all kind of getting the same information, and give us a better baseline for data.
Can you clarify for the rest of the group?
Yeah.
Number one, who hosts the TQIP data and what initiative that is?
Right.
And then the second, what is the source of that data for TQIP?
So the Texas Quality Improvement Project. So it's if anybody's involved at TQIP at the national level, we're actually looking at developing a Texas-based development project as well, so a quality improvement project as well for the state of Texas. Part of what the initiative at the national level is as well is there's not really a lot of quality improvement projects and or review of data at the pediatric level. So there's really a lot of initiatives and people trying to look at some of this pediatric data outside of the adult data and giving us a better idea as far as the information that you're required to report within the quality initiative and how we can make that more pediatric specific, and then if we can take that information and then assist with people in trying to look at what types of things for pediatrics we should be collecting from a data standpoint. So it would just give people, especially a lot of the adult hospitals that take care of kids, a better idea of what types of things, especially some of the pediatric centers want, what types of information are beneficial, what types of educational programs and stuff we could really target if we were all kind of capturing the same data. So I don't know if that understands.
Yeah, and please correct me if this is inaccurate, but that data is hosted by the American College of Surgeons.
It is,
through the
correct.
Committee on Trauma, and is a required part of
The Orange Book.
ACS
Yep.
designation.
Yep, for verification, yep.
I would love to talk with you more.
Okay, great. Thanks.
Thank you. Any other comments? Can I just say, after having been here for 12 years, this is one of the best reports that we have seen come out of this department, and it really helps us to understand the direction that we should be going in. So kudos for such excellent work.
Great, and we're happy to hear feedback about additional things such as what Diana requested.
Great, thanks. All right, we have, if we can move on to the last agenda item before public comment, and I do know that, I do believe we have a couple of people who had some items they wanted to talk about in public comment, and that is review and discuss any new best practices that we may have heard about for pediatric paramedicine. I think last we've talked about an EMS targeted issues grant for asthma and the role of paramedicine there. We heard you say previously that the education committee that subgroup has not met. Do we know of, and we made this regular standing item on the agenda, at least for the next couple of meetings, since we consider this to be an important transformation in healthcare. Anything to add, any new best practices either in the state or nationally that we need to be aware of?
I'll defer the state question to Charles as far as any updates.
There's no new updates.
On the national level, and I believe I mentioned this back in February, the Pediatric Emergency Care Council of the National Association of State EMS Officials, or NASEMSO, has been given the task of developing a community paramedicine pediatric portion. in conjunction with that Community Paramedicine Mobile Integrated Health Committee of NSEMSO. That is now an actionable item from the board of NSEMSO. So the Pediatric Council of NSEMSO is working with the Community Paramedicine Program to develop a pediatric portion of that that is specific to an injury prevention initiative. That is just in the very beginning phases, so not real sure what that's going to look like or what injury prevention initiative is going to be addressed just yet, but that is what is happening at the national level. And I believe, Dr. Shaw, you might be able to chime in on this, is NMSAC also working on a pediatric portion for that as well? Not to throw you under the bus.
So I am the pediatric emergency physician representative on the National EMS Advisory Council. And so in response to Mr. Vance's question, yes, there is a subcommittee on NMSAC that is specifically addressing the issue of community paramedicine and mobile integrated health, and they're currently working on drafting an advisory statement to be presented for recommendations to the Federal Interagency Committee on EMS regarding the issue of community paramedicine, mobile integrated health. So it's definitely at its early stages, so I don't have specifics to report regarding content. But I think that from the pediatric perspective, because on a national level, community paramedicine, mobile integrated health is rapidly growing, I think that it's essential for pediatric stakeholders to ensure that they address the potential role that a community paramedicine and mobile integrated health provider could have for the pediatric patient in the pre-hospital setting. And I think that it's essential that that stakeholder groups that represent pediatrics, such as this, provide that feedback as statewide or national organizations draft policy statements or advisories regarding it.
Thank you.
All right, if there aren't any more questions regarding the agenda items, we're now open for public comment. Did we have a CARES discussion? No. Okay.
One of the things that was mentioned a little earlier by Dr. Remick and Dr. Macias is that the EMS for Children National Resource Center has been sunsetted, and I spoke about this back in February, that Baylor College of Medicine in Houston applied for the new grant for the EMS for Children Innovations and Improvement Center, which is going to be kind of change the focus of the program to more of a quality improvement based program. I am happy to announce that Baylor College of Medicine was awarded that grant. Dr. Macias is the PI for that grant. So while it is based out of Baylor College of Medicine in Houston, this will be essentially the new National Resource Center for the EMS for Children program. So, but I'm going to let Dr. Macias talk a little bit more about that. Yeah, sorry.
Wasn't planning on that, but
yeah, I know.
thank you, Sam. I do think it's a great opportunity for the state of Texas, because much of what we put on national agendas will give us the opportunity to pilot much of that work and to work in synergy with the EAC. The intent by the Health Resources Services Administration, under which the Federal Emergency Medical Services for Children's program is allocated and funded, is to improve morbidity and mortality across the state. Most of that work is done through the assets of the PCAR network, which is the Pediatric Emergency Care Applied Research Network, which is an infrastructure for pediatric pre-hospital and hospital-based urgent and emergent care for children research. That provides infrastructure independently. It has over $50 million worth of research grants. The other research assets are the Targeted Issues Grants and the SPROT grants, which are regionalization grants offered across the country. In addition to that, there are state partnerships in 56 states and territories by which most of the work of the coordinating center is conducted. HRSA's move to transformation is taking what was once a passive coordinating center and transforming healthcare for improvements in morbidity and mortality through quality improvement strategies, using those assets and primarily driving much of that work through the state partnerships. So it really is a tremendous opportunity for the state of Texas to link to that work. While a lot of that work occurs independently, we certainly welcome, wearing the hat of the director of that center, certainly welcome any public comment, any of your thoughts for not just what you'd like to see in the state, but what you'd like to see happen nationally. We'll be having a lot more detail about what that looks like, but we anticipate moving certainly a number of the Quality Improvement Collaborative meetings, a number of the state partnership meetings, regionalization meetings, grantee meetings to the state out of DC, as most of our work will be occurring either virtually or out of the Texas area. So please give me your feedback offline, and we certainly thank everyone who has helped support the proposal and has helped assure that very significant funding to generate what I think will be a great next 4 years for pediatric urgent and emergent care throughout the country. Thanks. That being said, if there isn't any more public comment, I think we are done 20 minutes early. Anything else? All right, thank you for your time. We'll meet again in Austin during our August meeting.